Good morning, my name is Anna Kat, and today I'm going to be reviewing angiotensin-neprilysin inhibition versus enalapril and heart failure. Now this might sound vaguely familiar because there was a drug that came out by Novartis this year that was indeed a angiotensin-neprilysin inhibitor. That gives you kind of some foreshadowing to how this trial ended up. Now, we have some authors here, all of which are cardiologists, doctors, PharmDs, PhDs, and of course the funding was by, not a very big surprise, Novartis. A little bit of background includes that ACE inhibitors have already been long established for heart failure for about 25 years, but neprilysin inhibitors and ARBs, not so much. Now, the objective of this study, according to Dr. McMurray, was to come up with enough evidence, convincing enough to replace the gold standard treatment in these patients with heart failure, reduced ejection fraction. In other words, ACE inhibitors. But they didn't just want to use any ACE inhibitor, they wanted to use an ACE inhibitor that was evidence-based and was given in an evidence-based dose. So, how was the trial actually designed? Well, I have here a schematic that shows how it was split into three main phases. There was a screening phase, a single blind run-in period, and the main randomized trial. You see, we start off with about 10,000 in the main screening, and about 1,000 or so discontinued, going on to the single blind run-in phase, where the purpose of that was to make sure all the patients were able to tolerate both the drugs and their appropriate dosages that they were going to use in the main phase. So how it went down was about for 2 weeks, patients were placed on enalapril, 10 milligrams twice a day. Next 1 to 2 weeks, they were titrated to LCZ 200. LCZ 696 is a fancy long name. But LCZ 200 milligrams twice a day. At first they started with 100 milligrams, but they titrated to 200. Okay, so we have that. The location was really widespread over 47 different countries and 1,043 centers. The geographic regions ranged quite a lot from North America, Latin America, Europe, West and Central, and Asia Pacific. It was approved by each ethics committee at each study center, and all patients were provided written informed consent. Inclusions and exclusions. Inclusion criteria for the patients were basically that they had heart failure and other factors that indicated heart failure. And they had to have been on an ACE inhibitor or ARB therapy equivalent to enalapril, greater than or equivalent to 10 milligrams per day for 4 weeks before the screening even started. And they also wanted the patients to be on a beta blocker for 4 weeks, also 4 weeks before the screening. Exclusions included patients who were more prone to symptomatic hypertension, history of angioedema, systolic blood pressure that was just low, and a glomerular filtration rate that was less than 30, and high potassium levels. The subjects were, of course, adults with heart failure and with reduced ejection fraction was the main target, but heart failure comprised of the main umbrella. Primary endpoints included cardiovascular mortality, heart failure, hospitalization, or hospitalization from heart failure. The secondary endpoints included the primary, in addition to the KCCQ score at the 8th month mark, and if there was a new atrial fibrillation or renal function decline. So we have some other things, but I want to go back a little bit to if this study even matters. Now, with heart failure, there's still a lot of death, and it's major and prevalent still today. And ACE inhibitors have been a cornerstone for a long time and have been used as a standard of care in this disease since the 1990s. And ARBs are sometimes substituted for ACE inhibitors, but that's only if ACEs are poorly tolerated, so they're not really used. And even though beta blockers and aldosterone antagonists have further improved survival, mortality still seems to be pretty high. Now, neprilysin is an endopeptidase that breaks down vasoactive peptides like BNP, bradykinin, and adrenomedulin. Its inhibition, therefore, will hopefully reduce remodeling, vasoconstriction, and renal sodium retention, and improve the outcomes in heart failure with reduced ejection fraction. There really hasn't been any other drugs that have been similar to this other than omapatrilat. Omapatrilat, which is an agent that inhibits ACE, aminopeptidase P, and neprilysin. It did reduce mortality and hospitalization when compared to ACE inhibitors, but it was associated with a higher rate of angioedema. So that's where they came up with the idea of neprilysin inhibitor plus an ARB. So this combination is hopefully supposed to provide a better benefit over ACE inhibitors just alone in the treatment of heart failure, without increasing the rates of angioedema, of course. Now, if this study is actually valid and true, it can significantly change the way patients with heart failure with reduced ejection fraction are treated. It can significantly decrease their chances for hospitalization and even death. Now, to assess the validity, as mentioned earlier, we're going to jump down to the actual results now. And here we see that the primary endpoints and secondary endpoints overall, the ARNI therapy generally had a lower reduction in all of those endpoints. So the results were pretty significant because the therapy showed about 16 to 20% reduction in the endpoints when compared to enalapril, which is already proven to reduce the same endpoints by 18%. So that's the 20% on top of the 18%. And you can see that the p-value is indeed less than 0.05, which makes it statistically significant. Along with the reduction of the endpoints, there is for the cardiovascular death or heart failure associated hospitalization, the primary endpoints, the number needed to treat was 21. So, in other words, if you were treating 21 patients for the duration of the study, you would prevent one primary endpoint. For cardiovascular death, the number needed to treat was 32. And now, where there is an overall reduction in endpoints, we now have to compare it with the adverse events and how the two actually fared. You can see here that generally the LCZ was lower on most of the adverse events than enalapril, with the exception of symptomatic hypotension with a systolic blood pressure that was less than 90. That was a bit higher. And also the angioedema with no treatment or use of antihistamines only was also higher. But other than that, the LCZ was actually much better as far as the side effect profile than enalapril. Now we assess the strengths and weaknesses of the trial. Generally, the strengths were that it was a very large population pool with a wide geographic location, and it expanded within 3 years, so that gave a lot of data to come in. Weaknesses were really the fact that the enalapril dosing that was chosen for the trial was actually a little bit different than the one that's used in clinical practice. The dosing, despite the average mean being 18.9 milligrams per day, was aimed at 10 milligrams twice a day, and according to the ACCF/AHA practice guideline for the management of heart failure, the mean dose achieved in clinical trials for enalapril should be around 16.6 milligrams per day. And maybe the comparison between AR and I might have been more appropriate if it was an ARB for the control instead of an ACE inhibitor, but that's up for debate. In conclusion, ARNI therapy was superior to enalapril according to the data in the reduction of primary outcomes of cardiovascular mortality, heart failure hospitalization, and all-cause mortality. But despite the fact that the study had a large population and its similar trials are just lacking, and for that fact, it's not exactly clinically significant yet and shouldn't exactly be implemented. However, the results do yield a high perspective for ARNI therapy being a part of the guideline in the future, but a few more trials should be conducted to see if the results are indeed consistent and there is a true clinical significance. The good thing that actually came out from the trial, though, is the fact that the FDA did fast-track valsartan/sacubitril, the combination tablet called Entresto, and was approved this July 2015. So hopefully more clinical studies can be done. The drug might not necessarily be feasible right now since the average wholesale price for Entresto is $7.62 per tablet, which makes a month supply cost $457.20. But if more data does show that it can significantly decrease mortality, it might be a absolutely good option for the future. That concludes this journal club, and thank you.